My honor and pleasure to introduce one of the stars of oncology in the region and the head of the medical oncology department at Qasr Al Aini School of Medicine, Professor Mohamed Abdallah. He will talk about the choice of regimens in the first line setting, PARP alone or in combination. Thank you very much, Professor Mohamed.
Bismillah ar-Rahman ar-Rahim. Thank you, Professor Hasham, for your generous and kind introduction as usual. I admire the presence of the high distinguished panel, and I admire the kind invitation of my friend, Professor Basil Rif'i, and his team and organizers for this presentation. Definitely there is nothing to declare. We have to emphasize this. As we are talking about ovarian cancer, usually we are dealing with advanced stage of disease. And as we are dealing with such end stage or other later stage of life, we do expect that we are going to expose our patient to many of the treatment lines, with decreasing the durations for every phase, and the time interval between phases are going to be too short. So this decrease will be incremental over we are progressing, and our main job, trying to overcome the expected and anticipated resistance so as to increase time between phases of the treatment, so this will be translated into improvement of the survival of our patients. Moreover, that we are progressing, we do expect to have deterioration of the physical and the emotional well-being of our patients. So we need to keep the patient in every chapter as long as we are capable of this without disease progression. So the philosophy of keeping your patient without progression, it can be translated simply to the word maintenance. كلام مش حلو. مفيش حاجة شغالة. Okay, so we need to keep our patient stable without disease progression, with good physical and functional well-being as well as emotional stability. And as we are talking about the rather late stage of the disease, we need to be smart enough. We need to be strategic in our attack. We need to develop therapies directed to something that could help us to improve the outcome. For the epithelial ovarian cancer, the high-grade serous, about 50% of patients are going to show what we call some abnormalities regarding the homologous recombination deficiency, as well for the tumor suppressor genes, basically BRCA1 and the BRCA2. So this could be a target, since it's well established that DNA damage, if we are going to augment our attack, we can achieve lethality of the cancer cell. Based on this, we have introduced the PARP inhibitors through the concept of synthetic lethality, when the damage in the DNA is not going to be repaired. And the mono-PARP inhibitors had reshaped a lot of the therapeutic platform of the high-grade serous tumors, high-grade serous tumors, starting from the olaparib in series of trials, Solo 1, 2, 3, Study 19, and it was proven of positivity in achieving prolongation of the phase of the treatment through the maintenance treatment after the chemotherapy administered as a first-line treatment, and it was approved for patients with stage 3 and 4 resected for cure or receiving treatment, and we have a significant survival prolongation. Similar data, although less extensively studied, for the niraparib. But still, we are talking about advanced disease, and we do expect a developing resistance, and disease progression. And this is very well illustrated in many of the preclinical and the clinical works in the form of increasing drug efflux for the used PARP inhibitor, or some inactivation of the drug itself, or stabilization of the replication fork responsible for the repair of the DNA damage, also restoration of the BRCA genes, or deletion of certain protein that will push the repair pathway through the non-homologous end joining repair. All of them will be translated into drug resistance and cell survival instead of inducing apoptosis or cell death. So the common logic thinking, how can we do this job? Through combining the PARP inhibitor with something to improve its performance, prolonging the time and the duration of the treatment, and so on. We have the anti-angiogenic agents like bevacizumab, which was extensively studied in the ovarian cancer and others, as angiogenesis is a hallmark of malignancy. Also being in the immunogenic era, what about to combine the PARP with immunotherapies? But we need a rationale for this. First, for the anti-angiogenic agents, usually PARP, when intact, it will promote for overexpression of the vascular endothelial growth factor 1, and if it will, with other factors, combine with the receptors, this will promote the process of angiogenesis, and in turn, it will increase the vasculature of the tumor, decreasing hypoxia, not increasing the hypoxia, and this will be coupled with overexpression of the HRR, the homologous recombination repair in its wild form. So the cell survival will be promoted and we will have disease progression. If we use PARP inhibitors at this point, we don't have HRD, so we don't expect to have improvement when we use the PARP alone. But if we use any of the anti-angiogenic agents like the bevacizumab, it will block the theory. It will block this pathway, and here we will have a state of HRD instead of promoting the wild HRR, and there will be decrease of the cell survival and disease control. So it's logic to try to combine the PARP inhibitors with the anti-angiogenic agents, and again we have a reshaping of the therapeutic platform. We have the BAULA-1 for the most mature data coming for the combined PARP inhibitors and anti-angiogenic agents for patients with advanced ovarian cancer as a maintenance following the initial treatment, and we had really an impressive results, particularly when we consider those with just germline mutation or somatic mutations, and you can notice the significant, amazing hazard ratio. We are talking about 0.33, 0.43, but if we are going to consider the entire group of patients or the intent to treat population, it's going to 0.59, and for those with biomarker negative disease, it's nothing, it's 0.92. So we are in the era of precision medicine, so we cannot talk freely about all comers. We need to be more and more specific for the drug selection. Also, we have the ovarian trial for the niraparib, the recently introduced PARP inhibitor to the Egyptian market, and here there was no placebo arm, but the results were in favor again of all patients with statistically significant borderline values, but it was significant for those with HRD or BRCA mutation. Also, we have other anti-angiogenic agents with wider spectrum of activity. It's actually a multikinase against many of the receptors, which is the cediranib. When combined with olaparib, but for all comers following for patients who considered with platinum-sensitive disease, we have strong documentation for its use as a maintenance for patients in such a disease category. Immunologically, when we consider the use of PARP inhibitors going to induce the DNA damage, this will be coupled with a lot of events. Of them, we will have a lot of the neoantigens introduced, and this is the preferred situation for the immunotherapeutics. Also, we have overexpression of the PD-L1, as well for the presence of many of the cytokines leading to recruitment of the infiltrating active T lymphocytes, as well for the gamma interferon that's going to be overexpressed, and it's considered as a missile against the tumor. And we have a lot of data coming from phase 2 trials combining both the PARP inhibitors and the different immunotherapeutics. For olaparib, we have the durvalumab as one of the products of the Astra, and they try to combine it by what they do have, and for the NERA with pembrolizumab. So, before I'm going to stop, I have to remind you that the therapeutic platform of the management of ovarian cancer has reshaped a lot over the past decade, and we have many approvals regarding the available therapeutics for the OLA, NERA, and rucaparib. Although it's not available in our region, we can go if we have germline, somatic BRCA2 mutation. When we expand the spectrum for the HRD, all agents are approved in addition to the olaparib plus bevacizumab. And if we have a biomarker negative disease, I mean for the all comers not tested or negative, with some concern about this point, we have approvals for the NERA and rucaparib, although I'm not convinced by this to use it while we have negative biomarker in a country like ours. We are trying to focus on the precision medicine to save money, and before that, to save the patient in the right way. Thank you very much for your kind attention.